Hello, everyone. Good afternoon. We're going to go ahead and get started. Thank you for joining us for today's webinar. My name is Karen Bell, and I'm an Associate Director for Partners for Advancing Health Equity, or the P4HE Collaborative for short. We are based at the Tulane School of Public Health and Tropical Medicine, and we're sponsored by the Robert Wood Johnson Foundation. We are a national research learning collaborative that aims to bring together various sectors that are working on health equity, including government, academia, community-based organizations, philanthropy, and the private sector. Here at P4HE, we convene these sectors to work together to better understand critical issues related to attaining health equity. One of the ways we do this is by providing spaces for activities to engage with these groups and insightful conversations on timely topics and promote actionable solutions. Our goal for today's webinar is to promote actionable solutions related to anti-racism for health equity. Our field has come a long way, but not far enough. We have made declarations that racism is a public health crisis. We have put much more research dollars into articulating how racism impacts racial health inequities. However, our efforts on developing anti-racism in our field are, to date, insufficient. We need to develop tools and approaches to do anti-racism work and to address the barriers to doing anti-racism work that will inevitably surface. This webinar brings together cross-sector voices to share their insights on the role of anti-racism in the advancement of health equity. Our panelists will discuss ways that organizations across sectors can collaborate to develop and implement anti-racist health policies and practices that will improve health outcomes for systematically oppressed and marginalized populations and address health equity for all. So, before we hear from our panel, we of course want to hear from you. Thank you all for being here. Your opinions and insights on this topic will definitely drive the conversation and are invaluable to us. We'll be using Mentimeter, which you can access by scanning the QR code on your screen or by going to www.menti.com on your browser or mobile device and entering the code 58059618. Okay, getting a little excited about this. So let me slow down and put in www.menti.com into my phone and put in that code, which is 58059618. And once you put in the code, you hit join. You can, it says you're all set. You can do a little thumbs up to show us that you're there. All right, I see I see a lot of thumbs up. Okay, so yeah, once you get into Menti, you can do thumbs up. And then at some point very shortly, our first question is going to appear on the screen. All right, yes, somebody is hitting the next slide. Okay. The question says, what does anti-racism look like in our work? All right, so you can take a couple of seconds or however long you need to answer this question. You can put in multiple answers. I'm going to put in my answer. And hope you do the same thing. All right, so we should be getting some responses here. What does anti-racism look like in our work? All right, so I am seeing equity, centering marginalized voices and experiences, education, action, and accountability, ensuring that policies support health equity. Yes, we'll definitely talk about that. Policy change, unlimited growth, internal racial reckoning, and public apologies. Okay. All voices are heard and respected. Again, centering marginalized voices, using power for radical systemic change. Okay. Proactive intersectional. Oh, we get lots of responses. We're going a little fast. It's okay. Supporting small and BIPOC or BIPOC agencies. The Maryland Center for Health Equity is actively engaged in anti-racism work. using a health equity framework to address racial, ethnic, cultural, and socioeconomic health disparities. Thank you for that shout out. Sharing power with Black and other historically excluded communities in the form of funding and decision-making authority. Yes, definitely. Okay, I think we have another question. Yes, okay. All right, this question frames it a little differently. How should we do anti-racist work in the field of health equity? How should we do anti-racist work in the field of health equity? I am going to also answer that. How should we do anti-racist work in the field of health equity? And again, you can put in more than one response if you would like. And I see responses rolling in. Take your time. These are questions that are designed to help us think, but also to push our conversation with our panelists. So they are here watching and listening to what we're talking about right now so that we can incorporate what our audience is thinking into our discussion. So how should we do anti-racist work in the field of health equity, advocate and educate, create novel ways to measure racism wisely, okay, community outreach and engagement, recognize that despite legislation, rules, regulations being passed in various states, babies are born every day and those babies are browner every year. Change is inevitable. Okay, so talking about our demographic changes in the US by listening first, interrogate whiteness, speak up for unheard voices. Okay, seeing more responses roll in, representation, yes. Having everyone's view and concerns heard, yes. Team building exercises, continuous training, okay. If you can scroll down, thanks. Assess the structures that exist and where they create problems to better understand their solutions, education, collaboratively, okay. Oh, examine and uplift counter narratives. I definitely see that one. Thank you so much. Okay. As you all know, we work on working as a collaborative. So everything that you all share is going into this conversation and helping to push our field forward. So you can continue to share your thoughts and comments in the chat throughout today's discussion. You can also join this conversation with your questions and comments beyond this webinar on Twitter by using the hashtag partners, the number 4HE. Okay, so we're gonna move on to actually talking to our panel. First, we have Dr. Chris Purnell, who is the founder and CEO of the Esther Group and director of the NAACP Center for Health Equity. Hello.
Hello.
Thanks for being here.
Glad to be here with you.
Yeah, great. Next, we have Dr. Derek Griffith, who is co-director of the Racial Justice Institute and professor in the Department of Health Policy, Health Management and Policy, is different at every school, in the School of Health at Georgetown University. Hello.
Hello, pleasure to be here.
Awesome, thank you. Thank you for being here, and we're happy to have you. And then next we have Dr. Cheryl Evans Davis, who is Executive Director at the San Francisco Human Rights Commission. Hello.
Hello, how are you?
Good, good. Happy to have you all. As you all can tell, I've fumbled my words a little bit so far, and I think it's because I'm excited to have this conversation. First, thank you all for joining us, and I'm sure we'll have questions from the audience as well. But I wanted to start out by asking Dr. Purnell first, if you can share what anti-racism looks like in your work.
Excellent question. So I'll answer this first and foremost through the lens of being a director at the Center for Health Equity. with the NAACP. So anti-racism looks like elevating policy priorities that directly attack the disparities in health and healthcare outcomes that we see at 3 levels, the differences in life exposures and opportunities, and naming how racism is structuring opportunity within communities and within society as a whole, and thereby structuring exposures, right? Structuring the conditions in which people live, and then think about what are the policies that we as an association can advocate in favor of to disrupt the way racism unfairly and unjustly structures society. And then we also look at how racism structures access to care. And for instance, we go to who are the decision makers or who has decision-making authority around who has access to care in the United States, and how are Black populations in particular and other historically excluded and multicultural communities barred from access to care. So how can we advocate before those decision makers to do the reverse, assure the conditions, so assure access to care? And then lastly, how is racism structuring, influencing, shaping, or determining the quality of care that Black populations and other historically excluded groups experience? And so then how can we, one, define the issue and the problem? How can we sometimes provide research that elevates or amplifies the problem? And then how can we move to action? So is that fighting back against the backlash around DEI in medical education? Is that thinking through what are the specific needs of Black and other multicultural groups, and saying how do we impact those needs as they relate to having race congruent providers, right? Driving pipeline programs. And the last thing that I'll say is I am a public health and preventive medicine physician. So wearing that hat, in the words of Dr. Cameron Jones, a physician change agent, racism is often inaction in the face of need. So anti-racism is thinking specifically through the lens of need. What are the needs, the depth of the needs, the breadth of the needs, the complexity of the needs of Black populations and historically excluded groups? And what are the efforts that must be undertaken to disrupt that?
Thank you for that. I will ask the same question to Dr. Davis. What does anti-racism look like in your work?
Thank you for the question and for this opportunity. I would say we really, in San Francisco, especially where specifically to the Black population, that is less than 6% of the population, but still makes up nearly 40% of the homeless population, still makes up nearly 50% of those who are incarcerated, still makes up a third of the in schools and expulsions and suspensions that are happening. That it is about being very intentional about acknowledging these disparities and being able to say and recognize that it's not about the people, but that there are some policies and things that are in place that are perpetuating these kind of disproportionalities that are happening in both health and well-being, but also in terms of social and economic justice. And so that is a problem, I think, that when you talk about the banning of DEI or even the conversation around DEI, that we cannot, anti-racism is about saying we have to address the fact that racism is real and that it is actually being perpetuated by the systems or the policies or the programming that we've had over the years. And for us, being in my day-to-day work, it is really about shining a light on that and being intentional about how we dismantle that. How do we begin to address that it is actually embedded? And in some ways, the community would argue that it is intentional to keep certain people employed, whether that is about the police or whether that is about the programs that we have. Folks often talk about the nonprofit industrial complex. For some people, it is by design so that we can keep our capitalistic society moving forward. And that unfortunately, certain people are always going to be at the bottom so that other folks will have a job. And so I think for us, it's about how do we call that out? How do we bring attention to that, but not just recognize it, but work to address it?
You brought up some important points there that I think I will try to follow up on. Before I ask Dr. Griffith, I want to say why I asked him in particular to be on this panel. I'm a teacher, primarily a professor, and we teach about racism and how it impacts health, right? And so I spend a lot of time and energy describing all of the ways that racism impacts health. I explain what systemic racism, cultural racism is, all of that, and connected to health. And by the end of the class, my first couple of semesters teaching it, they're like, okay, this is tragic. What are we supposed to do about it, right? So then I said, let me specifically incorporate anti-racism in the class. And so Dr. Griffith, you wrote or co-wrote a paper called Anti-Racism Praxis, or about anti-racism praxis. And so I wanted to ask if you could talk about that, but also talk more broadly about anti-racism. But yeah, specifically about the praxis, because I think that a lot of people are like, oh, just like my students, you told us about racism, we get it, we agree, but we don't know what to do about it.
Yeah, no, thank you for the question. I mean, I think my colleagues have already done a tremendous job of talking about one part of the work, which is that we need to dismantle, disrupt, undo, mitigate racism in all its forms and in all contexts that we're thinking. I think anti-racism, though, adds to that and says, what is the world that we need to create? What is the vision that we have for what we want the world to look like? And how do you build on the assets and strengths of the communities that we have to create the world that we want? Even if you eliminate racism tomorrow, we're not going to have the conditions, the context, the resources in our community that we've mobilized to create things that are going to bring us joy, happiness, well-being, and just fundamental health. It is something that we have to, all of those assets, all of those, aspects of who we are and what the world means to us and the people that we love and all those kind of things that those mean to us, we have to create those conditions in addition to dismantling all the things that are holding us back. And so anti-racism to me is about creating the vision and implementing a vision for what you're actually trying to achieve while you're trying to also dismantling the structures that are getting in the way of what we're trying to do.
Thank you. Also, we'll follow up on a couple of things you said there as well. I do want to ask this question from the chat because it leads to my next question, but someone asked, to what extent can institutional policy be affected without dialogue and consensus among governing boards? So my next question was actually going to be, what are some of the barriers to doing anti-racist work or doing anti-racism? And I think that question gets at one of the barriers that I was thinking about, but I'll ask the broad question. What are those barriers to doing anti-racism?
I think one just key part to pick up on what Dr. Davis said about the current moment that we're in. I think one of the things that we haven't explicitly put enough attention to is narrative change. And that what has happened is that we've allowed others to redefine the key terms that are fundamental to the work that we're doing, redefine and co-opt the ways that we operationalize and define the goals that we have, the types of things that we're doing. And so I think a power framework is helpful for figuring out what kinds of things you actually are trying to achieve and do. So as opposed to just focusing on the decisions that are within an institutional context, who gets to decide and how do we decide what's on the agenda to even get decided? And how do we think about going the third level? How do we think about the narratives that decide what's even important to even consider putting on the agenda and therefore what actually gets decided? So I think we've sort of relinquished our power, if you will, to make those decisions, and we need to integrate that back in there if we're going to actually see some success, because what we're seeing is many of the things that we were trying to do, many of the ways we were defining the problems have been taken off the table. And so we're not even playing the same game when we're looking at DEI, because all of those things we're being eliminated from all those conversations because we're basically all those things that we were having as infrastructure are now being taken away. And so those are really about decisions and opportunities and agenda items that we're not even paying attention to because the narrative has changed and we haven't kept up.
Yeah, if I could just add something to that. The first thing that I was going to say in response to the question is relating an experience that I had as a healthcare executive. So I once was a senior healthcare executive at a safety net institution in Newark, New Jersey. And I encountered this. The complaint was I was catalyzing change at too fast a rate. And it did not allow those in governing or decision-making positions the opportunity to cancel those activities, if you will. I'm going to be very frank and honest about that. They won't use that language, right? This is where language is very important. And whenever I've spoken about this issue, whether to other healthcare executives or more broadly in community, when you find yourself within the four walls of an organization or institution, sometimes your change has to be underneath the radar before the status quo can fully understand what it is you're seeking to do. To give you all a concrete example, I recall there was a conversation about reimagining, envisioning future, right? There was a conversation about what should the facility look like? What should its design look like? And I was proposing involving community early in that process because it's community's understanding of what the healthcare infrastructure should look like that was most important, I thought, where others wanted to gatekeep and said, no, we need to further develop these plans before we invite community to weigh in, because we don't want to have the opportunity where community is misled into thinking something is possible when it is not. And I think that thinking in and itself is faulty. And that's because too often consensus making within institutions really is inauthentic and transactional, because it's not consensus making with the largest power, which is people, which is community. And I would say in public health, especially in my parlance and probably among yourselves, we frequently talk about sharing power, sharing power, sharing power. We need to fundamentally challenge. We need to fundamentally inspire. We need to fundamentally reimagine what it means to share power. And that has to be a bi-directional exercise, if you will.
I mean, I just love where this is going, because I think the idea of sharing power is still often just to check the box, like, oh, we had a community meeting and we heard from folks and we wrote it down, and now they have influenced how we will move forward. And that's not really the idea and notion of sharing power. And some of the best like breakdowns of like what shared power looks like have been actually from medical institutions that have said there's one piece where you go in and you just share information. That is not sharing power, right? There's another layer of this where you go in and you ask for information, and then the information does make its way into your report or your decision making. But that real shared power is about, we sit down, we have the conversation, and then you actually get to say, this is a good idea, this is not a good idea, this is what I think it looks like, and being very engaged in that way. And I think about individuals who know their bodies, right? And we saw this, like, but not everyone has the power of a Serena Williams to be like, no, this is what I need, and have people be responsive and actually save her own life. But that folks know and see and have the ability to kind of say, like, I've noticed that every time this happens, and folks will be dismissed because they're not a medical professional, or they'll say, hey, I saw this happening with another person in my family, and I can now see it happening over here. And I think the sharing of power sometimes, we think of it as who's the subject matter expert, and a lot of times there are people with lived experience that could be equally as informative through the process and as we engage that. And so that has been, I think, a real struggle for folks. But what we saw with the pandemic is that community members and folks that were organizing the food pantries and that were organizing food giveaways were like, okay, well, the food pantry is only, they only have Doritos as part of what they're giving out there. Like, you're asking people to make better food choices, but they're limited to what is actually being donated to the food bank. And so how can we be intentional about, for some of us, we were talking to folks about like, maybe we don't need Brussels sprouts in this community, maybe we need collard greens, and we can talk to folks about cooking them without ham hocks, right? Like, again, thinking about like how we share the power to be able to actually have the work get done. I often talk to my colleagues about, do we want to be right or do we want to be effective? And so we can be right and righteous all day long, and then nobody participates in what we're practicing, and we don't get to actually have the impact or the outcomes that we want. So I really see sharing of power as the best way to move things forward.
And can I just add one other quick thing to that, just from a diverse array of experiences where academic institutions and healthcare organizations in particular have struggled around sharing power, is they do not want to be authentic and transparent about the power differentials and asymmetries that exist. That's when you invite community in to be a part of a focus group. That's when you invite community in to do a survey. But you know very well that you're going to still go into a boardroom, or the decision-making authority lies outside of community. We've wrestled with this issue, whether it was when I was at Hopkins and we're thinking about what's a community health collaborative, or in New York, how does community, when they don't have the power of the purse, really direct priorities around how decisions are made, where dollars are apportioned? Because in order to share power, academic institutions, organizations, systems, and the status quo has to give up power, has to give it up in some way. That's where the difficulty, the challenge, and sometimes the inauthenticity lies, because those institutions or those systems are not ready or willing to do that.
If I could, Karen, just because in the Q&A, there was like a follow-up to this in that same spirit of like, how do we actually dismantle, disrupt, and what does that look like? And for us in San Francisco, when the pandemic hit and we were having these conversations about in our predominantly Latino communities, they had shifted the food to rice and beans and tortillas, and we're like doing things that were very specific. And in the Black community, we weren't seeing that same kind of focus for some of our elders who were asking for corn or green beans and so that really required like, okay, we're going to meet and talk with community, but it's the hard decision around doing what's easy versus doing what is best for community. And when we are talking about, to your point about like the decision makers, the ability to go into the room and make the decision or make the call, we have to have some courageous folks who are willing to be the only one maybe that will say, you know what, it might be more cost effective, but what good does it do us if we have all of this cheaper food, but nobody's picking it? So we're left with it week after week. So doing that analysis and kind of actually thinking about how we support folks who maybe don't have the data, but that we know how to maybe get the data and help tell the story from the lived experience. I think that is how we were able to change it, is to kind of go back and say, hey, if you are in this community and the folks are not actually coming to your food pantry, or they're coming and they're bypassing the things that you had, like, let's pay attention to who's taking it and who's not. So in that, from that qualitative piece of like how we collect the data and what that looks like. But I think the hard part is people don't want to make that investment. Right? We don't mind doing the focus groups, but we don't necessarily want to do the investment and the evaluation and the assessment on what it is that we might be doing wrong. And I think that that is the bigger picture. We're more than ready to study everybody else. We don't want to study our own practices. And I think putting some of that money on like, how are we effectively doing our job is also part of that change.
The chat is popping. Can I ask a follow-up question? Because somebody asked the question in the chat that that's what I would have asked. They say, what is the motivation of the powers that be to give up that power? What is the carrot for politicians and other people? And thank you for talking about politicians, because yeah, that's where we are. What is the carrot for politicians and other people in power to give up power when many of them are and have been benefiting from holding the power and maintaining the system status quo? Thank you for that question, because that's exactly what I was thinking. Go ahead. I'm sorry, I cut you off as well, Dr. Griffin.
Well, so I'm going to complicate this a little bit more. Is I wouldn't just say it's politicians. So as an academic, I think we kind of, I've gotten in the most trouble academically, particularly when I was a more junior scholar, for questioning who held power, for, you know, basically showing that we were trying to, as the academic institution, hold all the power, and that that was not an effective way to operate within a community context. And we'll can talk about that story another time. But my point is that one key thing I just want to say is that often we conflate or mix up the idea that being engaged with community, using a community-based participatory research approach, is actually anti-racist and is actually an effort to share power. It is not necessarily or fundamentally. It depends on how you do that work and what are the principles underlying it. How transparent are you, and what are you ultimately trying to achieve? It is not enough to just say you engage with people, you got an advisory board, all that kind of stuff where you're taking people's information and then you're still the ones who are making the decisions. Politicians do it. We as academics do it all the time. So we have to sort of, and we talked in some of the more recent work about the need to do inner work, as opposed to, often we talk about the outer work of the policies, the practices, the stuff that we're doing for others, as opposed to what do we need to learn, unlearn, relearn, and co-learn that are going to get us to the point where we can actually make the changes that we're talking about and embody the principles that we actually are saying are important.
I think that question is one of the smartest questions that we can elevate in today's conversation. And I'll first wear my physician's hat. During the pandemic, I think it was one of the first times, by nature of how coronavirus was spread, that we understood that those who were impacted by disease were not the only people at risk, because those who had not yet been infected were at risk by the sheer number of the amount of people already sick, right? And because people began to, or they were forced to understand the reciprocal nature of life, the communal nature of life, we were more willing to bend in certain areas to say, yes, it is important for the government to assure people to have access to medical care. That's why we were able to expand Medicaid during the pandemic, because the government felt compelled to use its power, right, to expand a federal/state program to give more people access to care, because if we didn't, it threatened the health of the entire nation. And so often when we don't have the context of crisis, people are more likely to protect their perch. With the context of crisis, people felt vulnerable. Those in power felt vulnerable. Those in privilege felt vulnerable. So it was in their best interest to make sure that those historically who had been disempowered had access to care. That is the conundrum that and paradox that we are faced with in American society. And I can tell you, as a physician who advocated for my mom when she was dying from severe Parkinson, healthcare didn't really care about her life. Healthcare systems did not care about the burden of caregiving for a woman with Parkinson's, but systems, governmental actors, and community more as a whole cared when their life was threatened, because we were all in this together. So again, going back to Dr. Cameron Jones, she says, you know, in naming racism and defining it, we must help society and systems understand that it saps the strength of society as whole. We have to begin to talk about racism in an economic cost as well as a societal cost. So then anti-racism can show the upside to its work, because it allows society to be more prosperous, and not just prosperous in the capitalist sense. And so I think that's what the struggle is. And oftentimes, and I'll end here, in the NAACP, especially through our work in the center, we're looking for ways to use storytelling, lived experiences, litigation, mobilization of frontline communities to do just that, to help those who have benefited from privilege to see how that is also a risk to the sustainability of the group as a whole.
Yes to all those things, because I think about it in the sense of for both points. I think about it in like from theory to practice. So I think about Cotter's 8 steps of change, which one of them is a sense of urgency, and it speaks to that, like without crisis, without fear of something happening to themselves or the impact of that. The guiding coalition is one of the principles that I most like think in terms of like how we get power to relinquish power or to be responsive to other folks. As much as we may want people to do things because it's the right thing to do, not everybody moves in that way, right? Like, and so that sense of urgency, that guiding coalition, and so what it has been most helpful for me in this work and advancing change and getting people to be responsive is the coalition of folks. I often joke that if you show up with too many people of color at one time in one space, especially if they're Black, people start to go, oh my gosh, what's going on? Where'd this mob of people come? We'll have 5 people and they'll be like, oh my God, they showed up with a gang of folks. And so what that looks like is now all of a sudden it's like, oh, we don't want people to be mad at us, especially politicians. Unfortunately, like the votes and the elections and things of that nature resonate. And so the narrative shift, the people showing up and being in space is actually what moves people. And a lot of times, even though we've shown, data has shown that diversity, equity, inclusion is actually good for the bottom line, is good for economics, that's not even enough sometimes to get people to do the right thing. So being very understanding what moves people or what inspires or what is important to them, and then showing up with that coalition that they will respond to, right? The folks that they care about, whether it's somebody that's going to vote for them or somebody that's going to write about them and that is going to impact the vote, like that piece around power, sense of urgency, and the coalition building is important. And then another one that I think is important that we sometimes are not strategic enough is the collective impact model, right? Like we start to plan, we come together as a group, but there's no backbone organization. There's nobody that makes sure that everything that we planned and talked about is followed through on. And then things get lost and then we seem disorganized or we seem like we're not following through. So being strategic, not just meeting and planning, but having and making sure that after the meeting and the planning has happened, that the plan actually gets implemented, right? That there is something that is moving forward, because it becomes really easy if you show up one time and then you never show up again. They begin to know the pattern and they begin to just be dismissive. They listen that one time and they go, okay, got it, wrote it down, thanks. And then you don't show up again until 2 years later when something else goes wrong.
I have so many follow-up questions. I need to figure out which direction to go. And I think first I want to highlight that we have talked about some of the issues that you all are bringing up in our previous webinar. So just want to lift that up, our programming. But also one of the ones that we had in December was called the economic burden of health inequities. And it was based on a paper or a study that the dean of our school and the director of this collaborative wrote with the head of the NIMHD and other colleagues. And one thing that has always stuck with me about making an economic argument is that when the economic argument is not enough, what are they actually saying about the people who are being marginalized and oppressed? Like we've tried to make these different arguments before, the moral argument, the economic argument, the sort of social identity argument, but what's happening when that doesn't work? And then what do we do once it doesn't work? Once we realize like, oh, you all don't care that it's costing us billions of dollars that Black people die at earlier ages, or we have high rates of whatever chronic disease among other marginalized groups. What do we do with that as a collective who does care about that? What do we do when that is it's clear that that's the view from the people in power?
Let me make your question worse. I think by not studying, this is why I was starting with that power framework and thinking about things like the book Dying of Whiteness, the folks who are beginning to start looking at the scholarship of whiteness, white identity, white structural factors, and looking at white supremacy as a construct, because we've typically operated from the assumption that people are going to act in their best interest and they're going to pass laws and make sure that things do that. What Dr. Purnell was describing earlier is, the policies from the Affordable Care Act and so forth very clearly showed in the expansion or lack thereof, they were willing to sacrifice their own health and well-being to basically maintain power, maintain the opportunities that they had within their particular community. So I think we have to change the way that we're thinking about the strategies. Like you said, we've gone through these various arguments, whether it's economic, moral, and so forth, and even tried to do things like create years ago, this was called the Commission for a Healthier America that David Williams led when this was probably trying to change the narrative around from healthcare to focusing on health more broadly, that they were trying to create these narratives and metaphors and so forth that would help bridge these gaps across groups. And that had modest at best effects. But I think the ideas are there, but I don't know that I have a good answer, but I think we have to ask a different question is my point.
Yeah, I can appreciate that, because where I was going to start is I don't think it's one or the other. I think the challenge that we are all faced with is when to flex one approach, one lens, one mental model or one tool as opposed to another. And to give clarity around that, ooh, I was going to say for centuries, because caste has been operating and white supremacy has been operating for centuries in the United States. But for decades, the scourge of substance use disorder racked Black and Brown communities, but it was nobody's priority in power. It was consistently and dogmatically spoken about and even acted around as a moral failing of that particular population or group. And it wasn't until, again, it is something that we're fundamentally missing about understanding the human condition, if you will. I'd love to have a sociologist lean into this. It's something that we fundamentally fail to absorb and understand about the human condition that's at play in our culture, in our society. Because when the scourge of substance use disorder began to impact not even white poorer communities, because we saw that with meth, but almost the randomness nature of it, if you will, that it could impact any white person, which really throws caste on its head, is when we began to think about a public health approach to substance use disorder. But then we saw, even within that approach to substance use disorder, that certain disparities were worsening during the pandemic around. We had Black and Brown folks beginning to die at alarming rates from heroin and other opioid overdoses during the pandemic, because it was like, oh, but we're focusing on this broadening approach, but neglecting the need just right in front of our eyes. I don't have the answer. I don't think any of us around this table have the answer. And I think we have flexed different muscles at different times to think about an economic argument, to think about a societal argument or approach, to think about a more of a collectivist understanding. There is something, and I will end here to give others the opportunity. There is something within the American culture and the American psyche that is so drunk off of the wine off of rugged individualism that we fail at really being introspective around what allows the group to thrive. When we figure that out, we can begin to get off of this pendulum of progress, right? Because it swings forward, then it counteracts and goes in the other direction. And I'm an optimist. I'm not saying we're defeated, but I believe that that's where we oftentimes find ourselves in the throes of battle.
If I could pick up there. So I actually started my career as a kindergarten teacher. and two of my, and somebody asked earlier about the arts, and I think the arts are really critical in this. I think culturally, from like the Black perspective, this idea of the arts, whether it's music and song or movement, all are things which we know are good scientifically for the body as well. But there are two poems that I always think about when a question like this comes up, like what do we do or how do we advance it? One is a Maya Angelou poem that has a line that says, "Don't show me frogs and snakes and listen for my screams. If I'm afraid at all, it's only in my dreams." And that we have created a society where it's easier to deal with the harsh realities and the disparities and the pain of the day-to-day life. It's easier to do that than it is to dream, right? And that we have normalized and come to just feel like every day is going to be a fight, right? That there's things are not going to necessarily work out, but that at the same time, Langston Hughes tells us, hold fast to dreams, right? And that ultimately, I think the optimism is what we, like, that's how we defeat it, right? But it's one step, one moment at a time. And that I think the need to stay hopeful is the piece that we have to do, right? And so had the chance at one point to meet John Lewis, and he was at a place and somebody said, how do you deal with it? How can you stand that, we haven't made any progress, things are not better? And he was like, we still need to do more. But if I look back over where he had come from, he's like, we have made progress, right? And so we can't lose sight of the progress. And so I would say that part of this is we have to use every tool in the toolbox, right? Like, so it's economic, it's social, it's all of these things. But a part of this is, for me, we also have to be strategic before we need strategy, right? So not waiting until we need the data to go and interview and connect with folks, because the distrust within science, within research, within data collection is very heavy in the communities that probably need the most resources. And we have to build authentic, real relationships in those places and spaces. And it also means sometimes we have to do things that we personally would maybe not do, or that we maybe don't understand or don't agree with. And I think that has been the hardest part in spaces where we know, quote unquote, what's best. And so we go in and we say, this is what needs to happen. And the community that we're trying to help is not checking for us, right? Like, is not interested in that, is not willing to share the information, and definitely not willing to show up on the steps of City Hall. And so I think part of this is building relationships, getting to know folks, understanding what resonates with them, being authentic, building community, centering community, right? And then evaluating how that relationship is going and making sure that it is not transactional and not one-sided, and that it is transformational and that it is mutually beneficial.
Oh, that was a lot. Somebody in the chat asked if this will be recorded and if the transcript will be available. I think yes and yes. Not I think, I know, yes and yes. What I was thinking, particularly while Dr. Purnell, you have been speaking, and one of the phrases or terms that keeps coming up for me is anti-Blackness. That this is not, it's not just racism, it's anti-Blackness that is driving this idea of, we know what's best, we're not going to do it, but you can make all these arguments as much as you want. Somebody sent in a question that I will read and combine with my next question. They say white counterparts, politicians, and other leaders often use weaponized incompetence to avoid doing anything against systems that benefit them. They say, how do we call them in and expect them to keep their word and get things done? And I think I will ask a broader question. How do we advocate for, not just advocate, but see through policy changes, given sort of the anti-Blackness that that we have sort of been lifting up or alluding to? What do we do to see those changes through, given the realities that we're in?
Yeah, I think it's important to right-size our understanding of what anti-Blackness is, because I've been in far too many circles where people are afraid or lack the courage to specifically call out anti-Blackness. And it's masked under the word of just racism. And yeah, racism, we must name it and understand how it's operating. But again, I think it takes us back to how caste operates in the United States, and racism around race and ethnicity, and Black race and ethnicity is something that has been very prevalent. I just want to piggyback on something Dr. Davis was saying. So sometimes I feel like I was born out of season because I'm the baby in my family, but my parents grew up in the Jim Crow South. So I very much had a front row seat to the horrors and the tyranny of the time in which they were born. And a part of that migration northward, and what motivated them. And in conversations with my parents and conversations with my grandparents, they could always acknowledge that there had been progress in the United States. They wanted that celebrated, but it got back to the crust that there had not been transformation in the United States. And because we haven't attacked, I believe, the beliefs around Black humanity, or how Black folks don't have the autonomy or don't possess the fullness of humanity, like Native and Indigenous populations and like so many other groups in this country. Because we don't have those very authentic and transparent conversations, our solutions fall short. I'm going to go back to that definition of racism. Racism is often inaction in the face of need. So anti-Black racism is inaction in the face of the need of what Black humanity requires in order to thrive and survive. And, you know, to use the lens of my parents, my mother would say to me oftentimes, Chris, you know the difference of where I grew up in the Jim Crow South and where you live in New Jersey? And I'm going to speak it to you the same way she spoke it to me. She was like, I knew what families did not want me in their house in Virginia. I knew clearly where I could and could not go. But in New Jersey, you will be invited over to dinner. You will sit down, you will sup, you will eat, and they'll put a knife in your back while you're ingesting a meal. And then say, but why are you in pain? So again, I think we grew into a more polite society in certain ways, but we haven't dealt with the belief around the disease of Blackness. And some people treat it like it's a disease and a sickness. And it's not until we can say, I will elevate this stat and then be quiet. We can talk about it until we're blue in the face that we need more Black and brown doctors. But when statistics and data can say the fact that there is one Black physician in a county improves life expectancy of the entire Black population in that county, regardless of whether or not those patients are seen by that doctor, shows you the power of elevating Black humanity and what Black lived experience and what Black decision-making born out of lived experience can offer to the complement of not only those historically excluded, but the whole. And we don't necessarily do that. We don't speak specifically through the lens of what do Black populations need.
Well, it's interesting because listening to you speak. So I'm born in Texas, but I grew up in California. And my grandmother and my mother used to say to me all the time, like, there was definitely something where there were no signs in Texas around like Jim Crow anymore, but I felt like I lived it. But I often say to people still today, especially in San Francisco, I prefer when I go visit home, because I learned when I was in Texas which streets to walk on, which neighbor's grass to avoid, all of these things. My grandmother was like, don't go over there, watch out for him. Like all of these things about like the very still existent Jim Crow. And I would say, as we are having these conversations, as we're moving through it, I think that the same thing around like transformation, I have those same views and thoughts, but I think part of it is, how are we actually, whether it's intergenerational, whether it is cross-cultural, whether it's the things that are happening in Gaza and Palestine, like these questions around like, how do we see people? And I think humanity is what I always come back to. It becomes so easy to talk about the issues and challenges that a global society or a community is facing. But when we have to really talk about people to people, person to person, the impacts of the things that are happening and what that looks like, people don't want to do that. And it makes it that much more difficult to actually advance the work, because we do not want to have difficult conversations. We don't want to talk about how the things that we are doing are embedded in really anti-Blackness, right? Or that we are dehumanizing people by not talking about the individual or the things that they are facing. And so that narrative shift, which we started with, Dr. Griffith mentioned in the beginning, I will just come back to, like, we are forever having to retell the story, and retell the story not based on the way that it was written to really dehumanize populations of people. And how do we begin to tell that story in a way that resonates with other folks, that people can actually hear it and not see it or feel it's just additional propaganda. But I will always go back to narrative shift, storytelling, whose stories get to be shared and how they get to be shared.
We are low on time, so I asked Dr. Griffith if you have any closing thoughts or a statement or anything. Go ahead.
Yeah, no, thank you. This has been wonderful. My just quick thoughts are that we have to stop assuming that everybody's in agreement and has the same goal of achieving health equity, and that we actually want equality in this country. And until we stop doing that and recognize that there are equal or potentially even more powerful forces trying to fight us against that, as there are trying to achieve it, particularly in the public health space, we're not going to be successful. I know that's a downer to end on, but I still think it's necessary. And just quickly, evidence of that, since Dr. Stephen Thomas is on here, some of the work that he did on the National Negro Health Movement and the success of it, but then why it ended, was evidence of that. The short version is that we saw success in actually closing the Black-white gap in life expectancy during that period. And then immediately, because they showed some success, not because we actually achieved equity, but we actually started to trend in the right direction, they closed the office and eliminated that office and stopped creating that infrastructure. So we can't keep assuming that just because we make the right argument that we're going to see those changes. Sorry.
No, thank you so much. I think that closing on reality is a good way to close, but also talking about the need for empathy and human connectedness that Dr. Purnell lifted up in the chat. I want to thank our panelists. Thank you all so much. And I want to thank our audience. You all are great. And I will also say that as we close this webinar, you can click the QR or scan the QR code on your screen to do a short survey to tell us if this was helpful. I hope that it was. We will also lift up, someone talked about the arts, or we've talked about the arts. I think it was Dr. Thomas talked about the arts before. I want to lift up our next webinar, which is on May 21st. It will be titled The Arts as Activism in Health Equity. You can stay tuned for our next workshop series coming early summer. Please also stay tuned for our new podcast episodes, which I have been a part of, and it's very exciting. They will be dropping this month through July. More information about our upcoming activities is available on our website, so follow us on social media and help us spread the word. Thank you all and have a great day.